And our next speaker is Dr. Lakshman Bandara. He's a consultant cardiologist from Nuwara Hospital. And he has done his overseas training in UK Portsmouth Hospital. So over to you, Dr. Lakshman Bandara. He's doing complication of heart failure.
Thank you very much. Ladies and gentlemen, first of all, I would thank the Sri Lanka College of Cardiology of inviting me for the lecture. I'll proceed with my topic. Yeah, so basically, why does heart failure patients develop end organ damage? So basically, my topic is heart failure with end organ damage, a special focus on kidney and liver damage. The basic principle of why these heart failure patients develop end organ damage is explained by the cardiogenic shock. So cardiogenic shock is the acute process where you get a cardiac emergency with the most severe form of acute heart failure, which results in cardiogenic shock. And the cardiogenic shock, the main cause for the cardiogenic shock is heart attack, especially the ST elevation myocardial infarction would give rise to cardiogenic shock, which results in hypoperfusion, congestions, and end organ damage. So regardless of etiology, cardiogenic shock is characterized by inadequate cardiac output, which is the pump failure, which leads to hypotension, ischemic injury, which results in symptoms of end organ hypoperfusion. So particularly the two end organs are being considered here, the kidney and liver damage. When the pump fails, your forward flow reduces and you get the ischemic injury. On the other hand, when the pump fails, your venous return will impair into the heart, so the venous congestion again will damage the end organs. So this slide explains how diagrammatically how this explains. For example, with a heart attack, the most common reason for acute heart failure or the cardiogenic shock, where the one vessel block and the part of the heart muscle is not working, the pump fails, the forward flow effect, and your cardiac output reduces, your blood pressure reduces. So as the pump can't push the blood out, the water will accumulate in the lung, which cause pulmonary edema, and the patient will develop the syndrome of heart failure or symptoms of heart failure. Addition to that, both end organs, the kidney and liver, will be affected either by the effect of the forward flow, the ischemic injury, as well as the backward congestion, the congestive hepatopathy and congestive kidney injury. So what are the acute liver injury which will happen in heart failure? So that can happen in both acute heart failure and chronic heart failure. As I mentioned earlier, the decrease in the blood input due to hypoperfusion will result in acute cardiogenic liver injury, which is the ischemic hepatitis. At the same time, the blood can't leave the liver because the heart is not accepting the blood, so it results in either acute or chronic congestive hepatopathy. In acute heart failure, the liver can be damaged with ischemic hepatitis, and in long-standing chronic heart failure, they can result in congestive hepatopathy, which leads to cardiac cirrhosis even. So what are the key features in management? The patient with encephalopathy, where the consciousness is affected, should be transferred to intensive care unit for monitoring. So when you are working in the in the cardiac ward, if the patient is developing this acute liver injury with a confusion and encephalopathy, you should consider discussing with the team to send the patient for where observations can be done maximally. Otherwise, the patient will die not due to the heart failure but due to aspiration and other complications due to impaired consciousness. Then the coagulation parameters can be changed when the patient in liver failure, especially the full blood count parameters should be carefully observed, and metabolic panel should be checked frequently, like venous blood gas or arterial blood gas. And serum aminotransferase, the ALT, ASTs, bilirubins are generally measured daily to follow the cause of the illness, where the patient is going for deteriorations or any other complications. Addition to that, the the sugar also need to be monitored frequently. So, what symptoms and signs will indicate the patient is in liver injury? So, if you are working in the ward when the patients are being daily assessed by yourself, okay, so if the patient is developing following symptoms like confusion, inversion of sleep pattern, for example, the patients are sleeping at the daytime and be awake at the night, development of tremors, bleeding manifestations, especially from the cannula site, development of edema, becoming yellow, icterus, would indicate the patient is in an ongoing liver injury. Addition to that, you'll be always going through this beta etiquettes daily, the rising liver enzymes, abnormal albumin getting low and the INR getting high, and increased level of gamma glutamate transferase or alkaline phosphatase, recurrent hypoglycemia. So those investigation will indicate the patient is getting liver derangement. So those are the important facts you should be consider while you are managing day-to-day practice. So at the end, as a summary, so what highlighting nursing care in this sort of a patients? First, the careful observation for symptoms and signs of liver failure. So if the patient is at risk of developing liver failure, or if the patient is in a process of going for liver failure, you should observe these symptoms and signs, because you are the first person who most of the time be with the patient, and you might be able to catch these early signs of liver failure if you are carefully observed. Then always you have to avoid constipation in patient with liver failure, because if the patient develop constipations, they are more likely to develop hepatic encephalopathy and other related complications. Then we have to look for potential sites of infection. So if the patient is in liver failure, a high possibility of getting infections and going for a complication of infections. So you have to observe the cannula sites and other potential sites of infections in day-to-day ward round clinical observations to avoid getting unnecessary infections. And you have to be aware with there are some medications which are harmful. For an example, the statins. The statins are very important in management of acute myocardial infarction. But if the patient with high liver enzymes in an acute or ongoing liver failure, the statin might harm. Sometimes antiplatelets are which are important in management of acute coronary syndrome, but if the patient with liver failure with high INR having high bleeding tendency, the antiplatelet might do harm. And some antibiotic, like especially the Coamus clave, can cause more congestion of liver if the patient is on already liver failure situation. And you have to be aware of the daily investigation for monitoring, like liver enzymes, INR, APTT would indicate the situation of liver failure at present. Then the procedures in a background of bleeding tendency, like doing an arterial or venous puncture, which causes more problems. So you have to be aware about INR before doing such a procedures. And you have to look for the complications like hepatorenal syndrome, which I'm going to discuss later. And you have to deal with the family members as well, because you are the persons who are dealing with more with the patients and the family would have a bridge between the doctors and the patients. So you have to talk to the patients' relations, explain the situations, what is going with the patients and what has happened to the liver, why it hasn't happened. So you have to have some idea about the pathophysiology of this sort of a complex scenario before talking with the patient relations. Well, so now we'll move into the second topic, the acute kidney injury in heart failure, or maybe acute kidney injury, or maybe chronic kidney injury in heart failure. Well, so what is acute kidney injury? So acute kidney injury is basically defined by an abrupt decrease in renal function, which is measured by GFR, the glomerular filtration rate, or reduced urine output, and which is frequent among patients with heart failure, either acute or chronic. So pathophysiology is quite complex, so that also explained by the failing pump, where the forward flow reduces and patient's kidney get the ischemic injury, as well as your pump fails, the backward congestion increases. In addition to that, there will be multiple mechanisms involved to develop these kidney injuries in heart failure. So basically this slide classifies what are the type of cardiorenal syndromes which can happen in clinical settings. It's quite easy to remember. The cardiorenal syndrome type 1, which results in acute heart failure, which results in acute kidney injury. Cardiorenal syndrome type 2, which happens in a chronic kidney injury as a result of chronic heart conditions. So the opposite happens in cardiorenal syndrome type 3 and 4, where acute renocardiac syndrome, if the patients have chronic acute kidney injury which result in acute heart failure, or cardiorenal syndrome type 4, which is a chronic kidney disease which result in chronic heart failure. Or sometimes a common disease can affect both heart and kidney, like in cardiorenal syndrome type 4, like in diabetes. So likewise, the cardiorenal syndrome, so there's a close association between the failing heart functions with failing kidney functions, which explains in different clinical settings. So what are the mechanisms of cardiorenal syndrome, which is quite complex and which include multifactorial causes, which reduces cardiac output, the pump failure, venous congestion, that is a backward increased pressure. When the ascites happens, intra-abdominal pressure increases, and in addition to that, there are a lot of neurohormonal activation happens. So this explains as a picture how it happens. Okay, so when the pump fails, renal perfusion will reduce, and your venous pressure increases, and your diuretics and other drugs also can contribute, and a lot of endocrine involvement, finally which results in vasoconstriction, reduced renal blood flow, reduced renal functions, and multiple injuries to kidney, which results in acute kidney injury or maybe long-standing kidney injury. In addition to that, the diuretic also plays, okay, the over-diuretic can cause kidney injury. So there should be a very cautious use of diuretics in the management of cardiorenal syndrome. So inotropes also would play a good role because it will increases the pump action and which helps the kidneys to perfuse well. In addition to that, vasopressin antagonists like tolvaptan can be used, and the tolvaptan also can be used in patients with hyponatremia, in patients with chronic heart failure, which is a novel drug which has been now used day by day. And sometimes you have to use these ultrafiltrations to give a renal support to prevent them getting into multiple cardiac problems. So as a summary, so what are the things to be highlighted in nursing care? As in liver failure, the careful observation of symptoms and signs of acute kidney injury is very important to identify these patients who are at risk at the early stage. Input-output monitoring is strict and should be done a very comprehensive manner, because then we can identify at which situation the patient is going for this acute kidney injury. And hyperkalemia is very important. So when you do take ECGs, just have a look whether the patient has hyperkalemic changes. And you have to be very aware about to avoid harmful medications. The patient in acute or chronic kidney injury, like unnecessary use of non-steroidal anti-inflammatory drugs. Usage of ACE inhibitors will be beneficial in heart failure, but not much benefit in acute kidney injury. And some antibiotic need renal adjustment doses. Addition to that, daily investigation for monitoring like blood urea, electrolyte, and serum creatinine also is important. And doing some procedures also might be making the matter worse or matter complicated, like in contrast studies in angiogram or a CT pulmonary angiogram might causes or might predispose a patient into contrast nephropathy if the patient is having ongoing acute kidney injury. So as in liver failure, you have to deal with the family members. So you have to be aware about what is going in the body, what is the pathophysiology, how it correlates with the heart problem into kidney injury, because these are the sensitive topics that you have to discuss with the patients and their relatives. So this diagram represents the same explanations when the heart attack happens, the pump fails, or due to any other reasons pump can fails, and it will directly affect the kidneys by reducing the perfusion pressure as well as increasing the venous pressure by causing congestive kidney injury. Yeah, so that summarized my talk basically. So I'll be I would like to highlight, okay, how the kidney and liver is getting affect when the patient in heart failure. So it can affect both in acute heart failure as well as chronic heart failure. Basic mechanism is when the pump fails, the forward flow reduces and you will develop ischemic liver injury as well as ischemic kidney injury. in addition to that, when the pump fails, the venous pressure increases, and which results in congestive hepatopathy and congestive kidney injury, which results in a complex mechanisms where the patient is going to have this multi-organ involvement, especially acute and chronic liver injury and acute and chronic kidney injury. Thank you.
Thank you, Dr. Lakshman, for your comprehensive presentation.